welcome to the Psychiatry and Psychotherapy podcast. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. One thing that created a lot of burnout and angst for me was trying to get continued medical education right at the last minute. So why not join the CME membership and do CME while listening to this podcast? Go to psychiatrypodcast.com, sign up, sign in, take the test, and the certification is emailed to you in seconds. Welcome back to the podcast. Today I am joined with Dr. Michael Cummings. He has no conflicts of interest, nor do I. And today we will be discussing Valproic Acid. We will be going through the history of Valproic Acid, the mechanism of action, the efficacy, talking about bipolar, schizophrenia, borderline personality disorder, anger, aggression, agitation in dementia. And then we will be going through some of the side effects, thinking about it as someone who treats people and what are the things that we look out for, what are the contraindications and drug monitoring, and maybe some things about how valproic acid actually helps people reopen critical periods of learning, like absolute pitch. Did you share that one with me, or did I find that one outside?
I shared that one with you.
Maybe we should start with the history, and we'll get to that eventually.
Okay. Essentially, valproic acid is actually derived from valeric acid. People may be familiar with valerian root, an herbal product sometimes used for anxiety or sedation. One of the compounds produced by that plant is valeric acid. Valproic acid essentially is a derivative. It's an 8-carbon branch chain fatty acid, a carboxylic acid. Formally named, it would be 2-propionic valproic acid or valeric acid. In terms of structure-function relationships, if you just had a straight fatty acid of 8 carbon atoms, it would not be active in terms of the brain. If you increase the number of carbons to 9, the substance becomes overwhelmingly sedating. If you reduce it to less than 8, it rapidly loses any central nervous system effect. So it's unique in terms of structure-function relationships in that regard. It comes naturally. Valproic acid itself is a clear, colorless liquid. If you make sodium valproate, the salt, it's an oily off-white powder. If you make sodium divalproex, 2 acid molecules joined to the sodium ion, you simply have a dry off-white powder. And we'll talk about that a bit later in terms of the commercial formulations that are available for medicinal purposes. Valproic acid was originally synthesized not as a medication, but was intended to be an inactive solvent for use in medical research. It was synthesized in 1882 by B.S. Burton in France. It was used as a solvent for a number of decades, and until 1962, indeed, people thought that it was an inert solvent. In 1962, research was done in which they were attempting to give animals compounds to make them have seizures, but those seizure-agenic compounds that had been dissolved in valproic acid resulted in the animals not having seizures, which led the researchers to look at the molecule more closely and say, well, how come this vehicle is preventing the seizures, but if we use a different vehicle, the seizures occur? And that led to the realization that valproic acid is an anti-epileptic drug, and indeed it was approved as an anti-epileptic in 1972 in France. Leap forward another decade to 1982, and we come to Robert Post at the National Institutes of Mental Health. He had been doing mouse research looking at kindling of limbic neurons using electrical stimulation, 1 second stimulus per day. If you do that in the temporal lobe of a mouse, After a few days, the mouse will have a complex partial seizure, a temporal lobe seizure. And if you keep doing it, the mouse will eventually have seizures even if you take the electrode away. Basically, the limbic system kindles over time and becomes overexcited in an independent manner. Post and his research group made a leap of logic at that point and said, well, maybe people with bipolar illness suffer from increasing rates of mood cycling over time because the mood cycles are kindling the limbic system the same way that our electrical stimulus did. So they initially tried carbamazepine, another anti-epileptic, to see if that would stabilize mood. It did, but carbamazepine comes with a whole host of adverse effects and is a very potent hepatic inducer. So it had a lot of problems with its usage. That led Post and his group to turn to valproic acid as the second anti-epileptic they investigated, and indeed they found that valproic acid is a mood stabilizer. It's much more effective against the manic pole of bipolar illness than against the depressed pole, but it also does provide prophylaxis. That is, it lengthens the amount of time between mood disturbances or mood cycles in the illness, which is how valproic acid made its way from inert solvent to neurology and eventually into psychiatry.
Wow. How would you define the mechanism of action and how it works for us in psychiatry?
In the broad sense, as was suggested by Post's work, it dampens the excitability of the limbic portion of the nervous system, the circuit of Pepez, including the suprachiasmatic nucleus, the biological clock. The mechanisms by which it does that appear to include direct blockade of voltage-dependent sodium channels. Influx of sodium via those channels is how neurons fire. It also alters the concentrations of guanine synthase kinase, which helps regulate cell excitability, as well as the activity of protein kinase C, which also is a second messenger modulator of just how excitable neurons are. Those taken in concert are thought to underlie why valproic acid provides greater stability in the limbic system. Over and above that, valproic acid also increases the synthesis and release of gamma-aminobutyric acid, GABA, which is the brain's primary inhibitory neurotransmitter. So it may be providing some direct inhibition by that route as well.
What about the NMDA receptors? Do you think that has much to do with it?
It does have effects at the NMDA receptors. Frankly, so far, we don't know how much that contributes to the mood stabilization. It may well contribute to the drug's ability to decrease overall neuronal activity. You know, this is a case of, because the drug does a number of different things, and we don't have the ability to change one thing at a time, we don't know what the relative importance of these various underlying mechanisms are.
Do you think the efficacy has something to do with modulation of the dopamine and serotonergic transmission?
Certainly in terms, I think it does in the sense that valproic acid alters the responsivity of limbic neurons to monoamine neurotransmitters, including dopamine, serotonin, norepinephrine. They are, of course, modulators of limbic activity. And in the case of valproic acid, it may be stabilizing the target neurons for those. And indeed, when we see overt clinical illness, often what we seem to be looking at is the limbic system is either overactive or underactive outside of homeostatic boundaries. In essence, the limbic system has gotten beyond the ability of the naturally occurring modulators, norepinephrine, dopamine, and serotonin, to modulate the system within homeostatic boundaries. So that's when illness crops up. Valproic acid and the other mood stabilizers, for that matter, may be functioning essentially to move the activity of the limbic system back into a range that the naturally occurring modulators can then manage.
Okay, so let's talk about efficacy. Let's start with bipolar disorder. And so in a recent systemic review, Joachim 2019, it talked about the different studies that have been done. Is that one you shared with me?
Yes, it was.
Okay. The review found that valproate is efficacious in acute mania compared to placebo, 45% versus 29%, so an odds ratio of 2, basically. And when they compared valproate with lithium, they found that there was little or no difference in response rate, 56% versus 62%. And they also found that little or no difference in the response rate between valproate and olanzapine, 38% versus 44%. So anything else that you would mention about efficacy with bipolar disorder?
Yes, there are differences among the drugs, although they are, rather than response in acute mania, the differences appear to crop up more with respect to prophylaxis. Valproic acid and lithium appear to have a longer survival curve between mood episodes than, say, olanzapine or the other second-generation antipsychotics indicated for mood stabilization. When they've compared the antipsychotics alone versus antipsychotic plus lithium or valproic acid, addition of the classic mood stabilizers provides longer-term stability for those people who tolerate them well. Lithium has the broadest range of efficacy. It's effective against both hypomania and mania, and also is inherently somewhat antidepressant. Valproic acid, in contrast, is as effective as lithium for the hypomanic or manic symptoms, but appears to provide much less benefit with respect to bipolar depression.
What about rapid cycling?
Historically, valproic acid was held to be more effective for rapid cycling disorder. More recent analyses suggest that there isn't that much difference between lithium and valproic acid with respect to efficacy in rapid cycling bipolar illness.
So, at what blood level is it going to be helpful for someone with bipolar, like hypomania or mania?
In people who are taking valproic acid for seizure disorders, the typical quoted therapeutic range is 50 to 100 micrograms per milliliter. The effective range for people with mood disorder or impulsivity, or traumatic brain injury or personality disorder appears to be somewhat higher, more in the range of 80 to 120 micrograms per milliliter. And that may simply be that modulating the limbic system is a somewhat more difficult task and requires a higher brain concentration of valproic acid. One of the pharmacokinetic properties of valproic acid is that it's very highly protein bound to plasma albumin primarily. At lower concentrations, it's 90% or greater bound. So if you have a fairly low plasma concentration, 8, 9, 10% of the drug is free and available to enter the brain. The rest of it's floating around attached to albumin in the bloodstream and not doing anything. By the time you get the concentration up, though, to 130 micrograms per milliliter, a little under 30% of the drug is now free, and only 70% is bound, largely because the albumin sites have gotten filled, and any additional drug is now available and free in the plasma. It's only the active drug that provides any treatment benefit.
And so this isn't like a linear relationship, is what you're saying?
No. When you get to about 80 micrograms per milliliter, further increases in dose produce a greater than linear effect in terms of increasing the free fraction of the drug available.
Are we talking about blood levels 12 hours after the dose?
Yes. Like most of the drug studies, even for drugs that have longer or shorter half-lives, most of the plasma concentration ranges you see cited are based on 12-hour post-dose measurements.
So if a patient comes in with bipolar, how would you select Depakote or valproic acid over lithium or over olanzapine?
Certainly, if the person has had a positive past response to valproic acid, that would be an element in its favor. If the person has reasons they can't tolerate lithium, they're not a candidate. For example, somebody with renal impairment is not a good lithium candidate. Then valproic acid may become the favored drug. On the other hand, if the person is intolerant of both valproic acid and lithium, or hasn't responded to either drug in the past, then olanzapine may become the drug of choice. The other thing that's available, of course, with olanzapine that isn't available with either valproate or lithium is olanzapine's available in an injectable form if the person is reluctant or refuses to take oral medications.
So what were you saying? Say that one more time about like if you're trying to keep someone out of mania, like in a stabilized state, is Depakote better or lithium or more of an antipsychotic? Which one?
Depakote and lithium are about the same in terms of survival curve. That is the average length of time until the next mood disturbance occurs. Olanzapine is somewhat shorter.
Okay.
So that olanzapine doesn't provide prophylaxis that is as good as the classic mood stabilizers. Now, in clinical practice, often what you'll see, especially if the person's bipolar illness includes psychotic signs and symptoms when they are in the throes of either depression or mania, they'll often be treated, especially initially, with both a mood stabilizer and an antipsychotic like olanzapine or other antipsychotic.
Yeah, I think that's something we see pretty frequently. It's like we want to get them out of that manic state. They're coming in, they're sleeping, 1 hour a day for several weeks now. And immediately, several medications are started to try to get them out of it. And even then it takes a couple days for them to get, 6 hours of sleep. It may take 4 or 5 days for them to start getting 6 hours of sleep per night.
Yes. Part of that has to do with, for these drugs, even once you've reached a therapeutic concentration, there is still an inherent lag time before the drugs begin to produce their clinical benefits. And that may have a lot to do with the fact that the underlying physiological changes require time for both lithium and valproic acid. That's one of the reasons that loading strategies have been developed for both drugs. In acute mania, the typical loading for valproic acid is 20 to 30 milligrams per kilogram. That is, you weigh the person, calculate what their total daily dose should be, and then give them, usually most people these days start with divalproex. You divide that dose into a BID schedule and you can simply start at the dose. There's no need to titrate. In fact, one of the common errors made with valproic acid is to start at a low dose. The problem with that is that, frankly, at concentrations of less than 50 micrograms per milliliter, almost all of the drug is bound to plasma albumin, and not much may happen because there isn't anything actually entering the brain.
Okay, so let's say you had like 100 kilogram male, so, about 270 or so.
Mm-hmm.
And this person was coming in, so you said 20 to 30. Mm-hmm. So it would be basically 2,000 to 3,000 milligrams divided over 2 doses.
Yeah.
That's where you would
which
start
means
them.
You'd be starting with 1,000 milligrams to 1,500 milligrams twice a day.
Okay. And then do you change it, or do you wait for the blood level?
Basically, the nice thing is with valproic acid is it will reach steady state for everything except the extended release formulation. It will reach steady state in about 70 hours. So 3 days later, you get a concentration, and you know where you are. Now, the 20 to 30 milligrams per kilogram will typically land you somewhere in that 80 to 120 micrograms per milliliter range. So you'll be in the therapeutic ballpark, and then you can fine-tune based on measuring a plasma concentration.
Okay.
And this kind of brings us to the discussion of the different formulations that are available, because there are a number. The most commonly used preparation these days tends to be divalproex, known as Depakote DR, D as in dog, for delayed release. Now, the delay in this case is only until the drug hydrolyzes in the distal stomach. It essentially was created to avoid upper GI upset acid reflux, which can occur with valproic acid in its liquid form or natural form. Depakine, the trade drug, is valproic acid, and causes quite a bit in terms of nausea or GI problems in some people. Also, there's a liquid preparation that is valproic acid. Depakote ER, the extended release, is essentially divalproex embedded in a wax matrix that melts very slowly in the GI tract. And the drug's actually delivered for absorption over about 22 to 23 hours. So it's almost like being connected to a continuous ongoing drip of valproic acid. It has a lower peak, produces fewer side effects, produces, however, a somewhat lower plasma concentration for the same total dose by about 10 to 15%. The liquid is also often more poorly absorbed and may produce a plasma concentration that's anywhere from 10% to 50% less than the divalproex. So a lot does depend on which formulation you're choosing. The extended release is intended to be given once a day. The divalproex DR can be given once a day however, you have somebody who's toward the more rapid end of the metabolic range for the drug. That is, they have a short half-life. That can result in an up to 80% decline across 24 hours. And that can put the person at risk of having a seizure due to the rapid fall-off in plasma concentration.
Wow. Okay. So anything else you would like to say about bipolar and this medication?
No, I think that pretty much sums it up for bipolar illness. Again, better for the manic end of the spectrum than for depression. Mm-hmm. Lithium has efficacy at both ends of the bipolar spectrum. Both are roughly equivalent in terms of prophylaxis, and both are slightly superior to olanzapine and other antipsychotics in terms of bipolar prophylaxis.
Okay. Let's talk about schizophrenia.
In schizophrenia, valproic acid has proven useful in part because of its rapid onset of action. Again, particularly if you load the drug initially, if you have somebody who is psychotic and agitated, valproic acid is pretty good at calming the agitation because, of course, psychomotor agitation is driven by the limbic system and particularly by the amygdala. And valproic acid is pretty good at dampening that, whereas the antipsychotics take a substantial amount of time to begin to actually work on the underlying positive psychotic signs and symptoms. Can take 1-2 weeks. Most of the antipsychotics begin to separate from placebo sometime in the second week, but you'd like to have a less agitated person during the first week. And that's often the reason for adding valproic acid. Now, in schizophrenic patients who do not have any element of bipolar diathesis, after the antipsychotics become fully available, valproic acid then does not add anything to their treatment. If, however, they do have elements of bipolarity, because remember, there is a great deal of overlap between schizophrenia spectrum disorders and bipolar illness. They share some 50% in terms of genetic risk sites. Those people who have some elements of bipolar diathesis, they may benefit from the mood stabilizing component on an ongoing basis. If somebody's just purely schizophrenic, though, by the time they're out beyond around 16 weeks, the valproic acid is no longer really actually doing anything for them, because by that point, the antipsychotic has taken hold and is providing the bulk of the therapeutic benefit.
In terms of studies, I've seen that it can reduce days in hospital like 1,
Yes.
or like not a lot.
It's not a huge effect in terms of hospitalization. For the person who is very agitated initially, it can be a useful tool. My own impression is that in many cases, we sometimes leave the valproic acid in place too long in those people who are purely schizophrenic. Now, if they have a vulnerability toward elements of bipolarity, they have a tendency toward irritable mood, impulsivity, mood elevation, those people may indeed benefit from ongoing treatment with valproic acid over and above what they're getting out of the antipsychotic. Conversely, I've also seen people admitted whose psychotic symptoms respond well to the antipsychotic, but who then continue to have irritable mood, difficulty sleeping, some elements of psychomotor agitation. And you may be looking at somebody who has an element of bipolar diathesis, even if they don't meet full criteria for hypomania or mania. And indeed, those people may benefit from valproic acid treatment on an ongoing basis.
So in the studies you gave me, I think it was Wang 2016, Casey 2008, it seemed like they were pointing to, there was not much of a significant difference in the PANSS positive scores. However, there was a slight difference in the PANSS negative subscale with the divalproics.
Yes, which may speak to the issue that the negative symptom scale appears to be more related to what could be termed affective elements in schizophrenia spectrum disorder patients. And indeed, it's that area where valproic acid may provide a benefit, and indeed lithium as well. It's clear neither lithium or valproic acid is an antipsychotic per se. If you had somebody present with positive psychotic symptoms, hallucinations, delusions, giving them valproic acid or lithium monotherapy would make them calmer, but it would not do a great deal for their core psychotic symptoms. On the other hand, if they have affective elements in the negative symptom domain, valproic acid or lithium may indeed be helpful to that person. Again, I would not characterize either of these drugs as an antipsychotic, but they may make useful adjuncts in those patients who have more negative symptoms or who clearly have an affective component as part of their illness. Which kind of brings us to other uses. Valproic acid's also shown efficacy in treating things like the mood lability present in borderline personality disorder, the mood lability or impulsivity present in traumatic brain injury, and even the behavioral disturbances sometimes that occur in neurocognitive disorders, although in the latter case, in the elderly demented, valproic acid does produce an increased rate of mortality, not unlike that seen with the antipsychotics in that population.
So there was this Hollander 2005 article where they looked at valproate for borderline personality disorder. Mm-hmm. They looked at 52 patients randomly assigned to treatment of divalproix or placebo for 12 weeks. They said that the median baseline aggression scores on the overt aggression scale was 33.5 in the divalproix group and 35.2 in the placebo group, which it's like a 2 difference. It doesn't seem like a very big difference between the two groups.
It is not a huge difference, and what you'll see is that some patients have a better than average response, but you're looking at a subpopulation. Certainly in terms of overall practice, the mood stabilizers have become the dominant pharmacologic treatment in borderline personality disorder, or I think ICD actually has it more correctly named. It's affective discontrol disorder. But it would be fair to say that none of the pharmacological agents are a primary treatment in personality disorder, including borderline personality disorder. Instead, they are adjuncts that may be useful for specific target symptoms in specific patients. That's also true of the antipsychotics. If a patient is prone to frequent dissociation or to what has been termed mini psychotic episodes, then indeed antipsychotics, particularly those that also have mood stabilizing properties, may benefit those patients. But the pharmacologic treatments are certainly not the mainstay of treatment for those patients.
Yeah, I think there's I see a lot of polypharmacy with people with borderline personality disorder. Like they come in on 9 TED medications.
I think in large part that's a byproduct of what could be called clinical desperation. There are people who are relatively refractory to treatment. I'm not sure, though, however, that we're doing them any favors by loading them with a lot of medications. I think a more reasonable approach is to try to identify 1 or 2 specific target symptoms that are impairing the person's ability the most, and then to target those with truly therapeutic amounts of a chosen medication. One of the errors I see made over and over again in doing consultations is clinicians will give, a little of this, a little of that, a little of the other. Giving 6 or 7 drugs at subtherapeutic doses does not really add up to a good therapeutic trial.
One thing I've noticed is that the partial hospitalization is really the best place for the patient that's just not getting better with, weekly therapy or weekly or monthly psychiatry visits. There was one really nice study on mentalization-based treatment where they looked at the medications and they compared it to controls, and they found that treatment as usual had quite a bit more medications after, the 8-year follow-up than the people in the partial program. What this shows me is that when people get effective treatment, and, this is partial for a couple, in this case, it was, twice a week for a year. That's a lot of therapy. And a lot of the times in the US, the most you can get is like 6 weeks, if that.
Yeah, which indeed is unfortunate because it's clear that people with personality disorders benefit greatly from effective psychotherapy, either mentalization or the classic dialectical behavioral therapy, those patients improve and change beyond simply having symptom reduction. I think the appropriate role of pharmacology in this context is as an adjunct to psychotherapy, to reduce specific problematic symptoms rather than a shotgun sort of approach of, let's try to cure a personality disorder with pills. Frankly, that's just not going to work.
I think one of the really helpful things from this discussion is that if the level of the valproate is under 80 for any psychiatric patient, it's probably not doing very much.
It's not because, again, below 80, about 10% of what you're giving the person is available to enter the brain, which means that, say, you're giving somebody has a plasma concentration that is right at 80, that means you have 8 micrograms per milliliter to enter the brain and actually do something. By the time you get to 120, you've got almost 30% as free fraction. So you've now gone from 8 to 36 micrograms per milliliter in terms of free drug, which is a huge change, much greater than a linear increase in the drug that's actually in the brain and doing something to benefit the person.
Yeah. And it's interesting. I find that I get a lot of new referrals of people who are on like 500 milligrams at night. That's it, and they're full grown males or females. And so it's like,
that's largely a placebo.
Right. The level in their blood is like 0.2, 0.3. Mm-hmm. And some of them think that it's helped, right? And so that's probably a placebo.
Placebos do help. As you can, if you look at any research study, I have yet to see a research study done in which the placebo response rate is 0. Mm-hmm. Giving somebody a sugar pill does things because the person believes that it will.
Yeah. In one of my episodes I did with Mark Ard, we talked about this one study on Parkinson's disease where they actually found that the placebo increased dopamine in the brain, mm-hmm. which Parkinson's disease is not, it's not a psychiatric illness. It's an illness where there's a dopamine deficiency. And so to find that a placebo actually increased the dopamine was pretty phenomenal to me.
Yeah. Same thing with studies of, for example, placebos for pain. Giving a person placebo increases the amount of enkephalin released because the person believes that it will help their pain. And indeed, it does help their pain, albeit not by a direct pharmacological effect. We should also talk about some of the adverse effects and risks of valproic acid because indeed it's not a drug to be taken lightly.
Before we get to that, can we talk a little bit about your thoughts on anger, aggression, both predatory and impulsive?
Okay. There's no really good evidence that valproic acid is effective for predatory violence. Impulsive violence, yes. Impulsivity or impulsive violence as well essentially appears to result from a lack of adequate top-down inhibition of the limbic system. By and large, the ventral prefrontal cortex is responsible for evaluating the potential consequences of our impulses. And in the case of somebody who's having violent impulses, essentially their prefrontal cortex is sitting there saying, no, don't do that. This is going to happen if you do that. When it's working. For a lot of our patients who've had traumatic brain injury or who suffer from schizophrenia or who suffer from an inadequate input from the temporal lobe to the frontal lobe in psychopaths, for example, that top-down inhibition is inadequate. And consequently, the person behaves impulsively without adequate consideration of the consequences. They leap before they look. The valproic acid can help that by essentially putting a brake on the activity of impulse generation. It makes the limbic system less active overall, and can make the person less vulnerable to impulses arising, for example, from the amygdala toward being violent. The other way that we can address that, of course, is if we can improve the functioning of the prefrontal cortex, we can improve the top-down inhibition. We see that with drugs like with clozapine, for example, or in the case of ADHD with dopamine stimulants. But for those patients for whom we can't improve their prefrontal functioning, the other side of the coin, if you will, is to decrease the limbic impulse generation.
One quick question on the clozapine. What blood level is needed for that frontal lobe optimization?
Depends on the diagnostic context. In people with personality disorders, it appears to be well below the concentrations needed to treat psychosis. Probably the best study in that area was Brown et al. At the Broadmoor Hospital in England, where they looked at 7 severely psychopathic individuals. These were antisocial personality disordered individuals who were very violent. They put them all on clozapine. The average concentration in that case series was 171 nanograms per milliliter. For schizophrenia spectrum disordered patients, the minimum threshold appears to be around 350 nanograms per milliliter, with most people having an initial target range of 350 to 600, and in more treatment-resistant cases, up to 1,000 nanograms per milliliter.
Okay. The one other group I wanted to ask you about is agitation in dementia. We looked at a couple studies, and it seems like it doesn't do very much. But do you have thoughts on when it's indicated or if it's overprescribed for agitation in dementia specifically?
It probably is, in part because its efficacy is limited, as you point out. The other element, though, in the elderly demented is that, at least based on the VA study by Maust et al., it had a number needed to harm of 26. In that study, they defined harm as death within 6 months. So if you treated 26 patients with valproic acid and among the elderly demented, you would cause one of them to die within 6 months.
So is there any indication for someone with agitation in dementia for using this medication?
There may be in some patients. Well, one of the other elements that came out of that study in terms of relative risk was that the very safest drugs in the demented elderly were the SSRI antidepressants. They produced a number needed to harm that was not that different than the placebo rate for number needed to harm. Trazodone also fell into that very low risk group. Multiple low doses per day can help decrease agitation and behavioral problems. After that, you got into the acetylcholinesterase inhibitors, and memantine also provided some benefit in terms of reducing behaviors that were undesirable. Valproic acid did have an effect, but it was small and had harm similar to that of the antipsychotics. So what we've tended to recommend to people is, if you have an elderly person who has behavioral disturbance, start with altering the environment. Environmental cues, orientation can go a long way toward reducing adverse effects. If those don't work, next steps to consider would be the SSRIs or trazodone or memantine and acetylcholinesterase inhibitors. Again, not much evidence of increased harm. Only if those didn't work would you move on to the mood stabilizers or to the antipsychotics. In other words, you would make the person earn the more dangerous treatment only by failing the less dangerous treatments.
Okay, we will be going into side effects now. Let's talk a little bit about the risk of neutropenia when it's used in conjunction with clozapine.
Okay. Clozapine, of course, can produce an autoimmune neutropenia. Valproic acid can also produce a neutropenia, in part because it is a histone deacetylase inhibitor, which gives it some of the properties of a chemotherapy agent. So it can lower cell mitosis by inhibiting DNA activity. Where that's problematic clinically seems to be primarily in terms of those people who are near a threshold for legal requirements in clozapine treatment. You may worsen their neutropenia. There's not any real evidence to suggest that treatment with valproic acid has a huge effect in terms of worsening the likelihood of an immune response to clozapine. But it can make the person more vulnerable to sliding below thresholds for mild neutropenia, moderate neutropenia, and perhaps in some people who are already in the moderate range, pushing them into more severe neutropenia. That's been held to be essentially a precaution rather than a contraindication, because, for example, in patients who develop clozapine-induced seizures, valproic acid is a highly desirable drug in those patients in terms of controlling the seizures.
Let's talk about hepatotoxicity.
Hepatotoxicity is present. Valproic acid can cause hepatitis, and indeed it's contraindicated below 2 years of age because it can cause acute hepatic necrosis. In older persons, some elevation of transaminases is not unusual. Elevation of ammonia occurs in almost everyone. That's not a call to measure ammonia in everyone, because you should really reserve measurement for those people who develop evidence of delirium, because everyone will develop some increase in ammonia. Most of those cases will not have any clinical effect. Where valproic acid seems especially dangerous is when it induces pancreatitis, which is another risk, and that then also comes to involve a hepatitis that goes along with the pancreatitis. That can be very dangerous, and indeed the acute pancreatitis can be severe and can result in essentially the death of the pancreas.
Are there any things to consider when watching people for acute pancreatitis? Obviously, the pain of acute pancreatitis is usually like in the middle of the stomach, and it's like stabbing to the back, or just
yes,
very, very painful.
Yeah, indeed, you should look at the person and you should educate, of course, the patient to, if they have abdominal symptoms that have central pain with radiation to the back, they should report that immediately. Like most medications, adverse effects with valproic acid tend to occur early in treatment, which is why the monitoring advice tends to be monitor more frequently early in treatment. For example, in the Department of State hospitals, measurement of valproic acid, plasma concentrations, amylase, lipase, hepatic functions occurs weekly for the first month, and then every 2 weeks for the months 2 and 3, monthly for months 3 through 6, and then after that it's every 6 to 12 months, or as clinically indicated. Because indeed, if there's going to be an adverse effect, it will be early in treatment in most cases.
That seems pretty frequent. I mean, I don't think we're doing that outpatient or in a psychiatric
in the community it
hospitalization.
tends to be less frequent, since we have people inpatient and the labs are more easily available, and we're often treating people very aggressively in the state hospital system. The more monitoring is correspondingly more aggressive as well.
So would you say that if someone had hepatic dysfunction, it would be a contraindication for this medication?
If they have a urea cycle disorder, yes. Because indeed, one of the effects of valproic acid is to inhibit the urea cycle, and you may produce hepatic encephalopathy in people who already have a urea cycle disorder.
Can you tell me, like, just what is a urea cycle disorder?
Oh, usually an inherited disorder in which the person does not adequately attach ammonia to make the molecule urea. Essentially, the liver manufactures urea, and then the kidney clears it in the urine. If that cycle is defective, and the person already has difficulty with making urea, adding valproic acid to the mix will make them worse, and very likely may give them an episode of hepatic encephalopathy.
So I know, like, a really common board question is, and maybe you have a seizure patient or bipolar patient, and they come in with and they have an isolated, very, very high ammonia level. Mm-hmm. How would you manage that person? Or would that person have liver disease just with that isolated high ammonia?
High ammonia by itself may or may not produce encephalopathy. Now, obviously, if you get ammonia high enough in anyone, you will begin to impair neuronal function. But people vary widely in terms of how sensitive they are to their own ammonia. Some people tolerate levels under 150, no problem. With most people, by the time you're getting up to levels of ammonia around 200, you'll begin to see evidence of confusion, difficulty concentrating, some loss of orientation ability. And beyond that, eventually, at some point, the person will develop an overt delirium. What you often see with ammonia in the context of valproic acid treatment, though, are elevations, but elevations up to around 80, 90, 100, and most of those people walk around just fine with no adverse effect at all, which is why we don't typically encourage routine monitoring of ammonia. Because you'll get abnormal lab values, but, well, what do you do with it if the person's not clinically ill?
Yep.
The other area I wanted to touch on, which is very, very important, is valproic acid should not be given to women who are pregnant. Aside from what everyone has learned about neural tube defects, which are bad enough, the fetus suffers tremendously on exposure to valproic acid. There's roughly a 10-point decline in IQ if the fetus is exposed to valproic acid, and the rate of autistic spectrum disorder doubles with such exposure. That goes back to the role of valproic acid as a histone deacetylase inhibitor. It essentially impairs DNA functioning, and that's critically important when you have cells that are differentiating and trying to adhere to the right places, migrate to the right places. Valproic acid can interfere with all of those processes. Now, in the adult brain, interestingly, valproic acid can also cause a much milder de-differentiation of neurons. And that brings us to the point you raised early on, that you can teach adults perfect pitch if you give them valproic acid, which is something that normally in the differentiated brain you can't do. Most of us learn the ability to gain perfect pitch by around age 4 years. But there was a study done that was a fascinating study looking at cell differentiation, in which they gave adults, otherwise healthy adults, valproic acid, and they were able to teach the majority of them perfect pitch.
Yeah, and all of these studies will be in the resource library handout, the PDF that will go in the free resource library if you follow the show notes, or just go to psychiatrypodcast.com. It's pretty easy to find. What about hyponatremia? Hyponatremia
is also a potential adverse effect of valproic acid. It can cause inappropriate secretion of antidiuretic hormone, which acts, of course, to prevent the kidney from clearing water, which leads to, of course, a buildup of free water in the plasma and consequent hyponatremia. It is moderately dose dependent. That is, the higher the concentration of valproic acid, the greater the effect becomes. An important issue in many psychiatric patients is distinguishing between SIADH, syndrome of inappropriate antidiuretic hormone secretion by the pituitary, versus simply excessive water intake, polydipsia, psychogenic polydipsia. You can tell the difference by looking at both the plasma and urine at the same time. In the case of too much water intake, the kidneys are still clearing water just fine, so you'll wind up with a very dilute plasma and a very dilute urine. In the case of SIADH, the problem is the kidneys are not clearing water, so you'll wind up with a very dilute plasma and a relatively concentrated urine. So if you look at both, you can tell which you're looking at.
Okay. Any other side effects that you wanted to mention? We know there's hirsutism, so increased hair.
There's hirsutism. There's also, conversely, alopecia, which in particular will be a problem for some female patients who don't particularly want to have thinning hair or balding. And in those patients, often treatment with selenium may help prevent the hair loss. Minoxidil also can be helpful both in preventing and in reversing the hair loss, as long as it's applied early enough. If you wait until the person's completely bald, the minoxidil is not so effective.
Wait, so it both balds and increases hair? How does that work?
This is a drug that inhibits cell activity at the DNA level. In some cases where there's a chronic inhibition of the follicle by other cells, if those regulatory cells get turned off, you get hair growth, particularly on the face. On the other hand, for follicles that are supposed to be active in dividing, just like any other chemotherapy agent, you can cause hair to fall out and be lost.
Mm-hmm. So, not the best drug for young women who are sexually active, or just young women in general?
No, has also been associated with polycystic kidney disease in young women.
In young women, okay. Any final thoughts on side effects that you monitor for with this drug?
I think the principal ones are to indeed monitor the person for any neurologic side effects such as ataxia or confusion, and also to, at a reasonable level, monitor for any GI effects. Again, adverse effects are much more likely to occur early in treatment when you're introducing the drug as opposed to in people who've been on the drug for a long period of time. And of course, in women in their childbearing years, they need to be very carefully educated about the risks of valproic acid.
Okay. Any other final thoughts on, this medication?
I've always been impressed that for something that was supposed to have been an inert molecule, it turned out to do a lot of things, everything from being an anti-epileptic to a mood stabilizer to now a chemotherapy agent that's being used adjunctively to treat cancer. That's quite a range of things for something that was supposed to be inert.
Yeah. Okay, well, we will leave it there for today. Once again, we'll have these notes, the links to the studies, things that you can explore further, share with your colleagues or students that work under you, and we'll put that in the resource library for free. You can just go there and get the PDF and share it, and we'll leave it there.
Okay, sounds good.